Hello, everybody, and welcome back to Moose Med. Today, we're going to be conquering week 1 of endocrine, and let's jump right into it. So, endocrine glands are ductless, okay? Meaning they do not release their products into tubes like exocrine glands. So, for example, an exocrine gland would be like salivary glands, okay? So, instead, hormones are secreted directly into the bloodstream, which allows them to travel systemically. However, hormones do not act everywhere. They only affect cells that express the specific receptor for that hormone. So no receptor, no response. This is fundamental exam logic, okay? So compared to neural signaling, neural is going to be really fast, milliseconds, and it's going to be very short-lived. Whereas endocrine is going to be a bit of a slower onset, minutes to about hours, and a much longer duration, so hours to about days. Why? Well, that's because endocrine signaling often alters gene transcription or protein synthesis, which takes time but produces sustained effects. So the endocrine system is built to regulate growth, metabolism, reproduction, fluid balance, long-term homeostasis. So most endocrine systems operate via something called negative feedback, okay, meaning the final hormone produced will suppress earlier steps. And we'll see a lot of examples of that going forward. But that's the main idea there. So if you understand negative feedback, you understand about 70% of a lot of the endocrine pathways and a lot of those problems. Okay, so hormone behavior is determined by chemical structure. So the first one we have is protein peptide hormones. So the examples will be insulin, growth hormone, and big takeaway here is exactly what's on the slide. They're water-soluble, cannot cross lipid membranes, bind to cell surface receptors, and activate second messenger systems. A second messenger system is an intracellular cascade, right? So, for example, you got your cyclic AMP or CAMP for short. And so the effects of that are rapid, short-lived, and often modify existing proteins, okay? So that's your protein peptide hormone. And then next you got your steroid hormones, okay? And these are derived from cholesterol, and we'll get into the synthesis of that later on. But your examples of a steroid hormone will be cortisol, aldosterone, estrogen, testosterone, all the ONs. They are lipid soluble, and they cross cell membranes easily. They bind to intracellular receptors, directly influence gene transcription, and these hormone receptor complexes act as transcription factors in the nucleus, okay? So the effects are slower onset and longer duration, and they literally change what proteins the cells produce. Finally, we have amine hormones, which are kind of a hybrid of the two. So derived from the amino acid tyrosine, okay? Two important subgroups here. You have catecholamines and thyroid hormones, okay? So both of those are amine hormones, okay? So catecholamines, like epinephrine and norepinephrine, are water-soluble, act like peptides, and are very fast. Then you have thyroid hormone, and that's lipid-soluble, but it acts like a steroid, and it's slow and long-lasting. Okay, so they share the same origin, but they have different behavior. So thyroid hormone more like steroid, and catecholamines more like peptide. Okay, so endocrine feedback loop. So the classic pathway is hypothalamus to the pituitary gland to the target gland. Okay, so an example here would be the hypothalamus releasing TRH, okay, which is thyrotropin releasing hormone, and that will then hit the pituitary, which will then release TSH, which is thyroid stimulating hormone, and then finally the thyroid releases T3 and T4. So the final hormone, T3 and T4, feeds back to inhibit both the hypothalamus and the pituitary gland. Okay, so that's an example of that feedback inhibition. And do not worry, all these will have their own slide. This is simply an example. So this is called a long loop negative feedback. If the target gland fails, target hormone decreases, pituitary hormone increases. And the reason it's a long loop is because it's inhibiting a step that came before it, but it's not the step that came immediately before it, okay? That would be a short loop negative feedback, all right? Okay, so just real quick here, because there will be a lot of clinical correlations later on that deal with primary versus secondary disease. So just real quick definitions, right? So always locate the problem first, all right? So primary just means the problem is in the target gland. So an example would be thyroid destruction. Okay, so your target hormone will then decrease, and then your pituitary hormone will increase because feedback is lost. All right. Secondary would be the problem is in the pituitary, for example. Okay, so the target hormone would decrease, pituitary hormone would decrease. The pituitary is failing, so it does not stimulate the target gland. The pattern tells you the location. So basically, broadly though, because you're going to see primary versus secondary diseases outside of just pituitary and hypothalamus, right? Hang on to that core definition. Primary problem is the target gland. Secondary problem is something that either came before it or is further downstream in whatever pathway it's involved in. All right, so the hypothalamus is the master integrator. It controls hunger, thirst, temperature, sleep, endocrine output, autonomic nervous system. The autonomic nervous system includes your sympathetic nervous system, so that's your fight or flight response, your parasympathetic nervous system, that's resting and digesting. So it also integrates limbic input, okay? That's emotion. So that's why stress affects endocrine function so much. Anatomically, it sits below the thalamus and connects directly to the pituitary gland, okay, making it the control center for endocrine regulation, okay? All right, so the hypothalamus is divided into two structural zones. You have the medial zone and you have the lateral zone. The medial zone is, it has organized nuclei and it has precise functions, whereas the lateral zone is a little bit more diffuse and is associated with hunger behaviors. And then you have three anterior-posterior divisions. Okay, you have the anterior or preoptic region. You have the tuberal or the middle region, and you have the posterior, which is the mammillary region. All right, so now we're getting into the hypothalamic nuclei you must know. Okay, so these are the nuclei that are located in the zones in the hypothalamus. All right, so we have the preoptic nucleus first, and this is going to regulate body temperature. Okay, this is where the cooling center happens. Okay, then you have your supraoptic and paraventricular nuclei, and these guys produce ADH and oxytocin. ADH promotes water resorption and reabsorption in the kidneys, and oxytocin causes uterine contraction and milk ejection. So these hormones are made in the hypothalamus but released from the posterior pituitary. And we'll get into this a little bit later, but it's important to note that the posterior pituitary does not actually make any hormones. It is simply a storage for the hypothalamus, okay? We'll get into it later, like I said, but I'm just bringing it up here. Then you have the suprachiasmatic nucleus, which controls your circadian rhythm, and it receives input from the retina. So light resets this clock, which is why blue light on your phones makes it harder to fall asleep, etc., etc. Then you're going to have your ventromedial nucleus, and this is your satiety center, or satiety, basically when you know you're full. So basically, if you have a lesion here, it's going to lead to overeating, which will lead to obesity. And this is how a lot of these will get tested. They will ask you, you have a lesion in this zone that affect so-and-so nuclei, or the patient is now expressing these symptoms. What got affected, right? And then finally, you're going to have, or it's not finally, right before finally, you have your lateral nucleus, which is the hunger center, okay? So if you have a lesion here, you'll see decreased appetite and eventually weight loss. And then finally, you're going to have your posterior nucleus, and this is sympathetic activation and heat conversion. And the way I like to remember these is the little photo on the slide here. And I really recommend just drawing this out a couple times. So on test day, on your cheat sheet, you can just write that real fast as soon as the exam clock starts. Just try to write this out if nothing else is helping. So the way we have our diagram set up here, on the far right, you have that lateral side. And the way I like to remember that the lateral is responsible for hunger is I'm laterally so hungry right now, okay? And then with how our diagram is organized, the very top portion of that middle center of three squares has an up arrow because it's at the top. Coincidentally, it also means an increase in temperature, okay? So that's going to be your preoptic nucleus, all right? And then moving down from there, we're going to have your ventromedial nucleus, and that's going to be your fullness. And the way I like to remember that is because it's the middle square, that's where your tummy's at. It's nice and full. And then at the very bottom, you're going to have your posterior nucleus, okay? And this has to deal with decreasing temperature, okay? The way I like to remember this is cool butt, bro. Cool butt. Posterior, coolness, there you go. The other thing that it does is that increase in sympathetic activity, and the easy way I like to remember that is people with nice butts have a lot of simps. So there you go. The final one I have a fun little way to remember is going to be that suprachiasmatic one, and also dorsal medial, which they are responsible for the same thing, which is going to be your circadian rhythm. And the way I like to remember that is because if you are lying on your back, you are lying on the dorsal side of your body. Normally, you like to lie in the middle part of your bed, medial. And when you lie in your bed, you make a big chasm, a suprachiasmatic. Right? You see what I did there? So, suprachiasmatic and dorsal medial are responsible for your circadian rhythm because it has to do with sleep. The other ones, unfortunately, I just recommend drilling a couple times. You'll get them in there. But that should get you really far. Okay, so hunger and satiety logic. So with the lateral nucleus, again, you're laterally so hungry, right? It is stimulated by ghrelin, which we covered in our GI videos. So ghrelin is released from the stomach during fasting, right? It's what makes your tummy grumble. It doesn't actually, but that's how I remember it. Ghrelin, grumble, you're hungry. It's inhibited by leptin, and leptin is released from adipose tissue or fat and signals energy sufficiency. So the lesion of lateral nucleus will lead to weight loss because you are no longer getting that hunger sensation. And then, again, you're going to have that ventromedial, which is satiety. And I went over this all on the last slide, so I'll end it there. Okay, so again, we're kind of retreading what we covered in that one mega slide there, but just to hone in on some temperature regulation. Again, we're going to have that anterior or preoptic hypothalamus, all right? And that's going to be where your cooling mechanisms lie. So like sweating or vasodilation, blood vessels widening to release heat, right? And then you're also going to have your posterior hypothalamus, the cool butt, bro, right? So heating mechanisms. So shivering or involuntary skeletal muscle contractions, and then vasoconstriction, so narrowing blood vessels to conserve heat. So the anterior cools and the posterior heats, all right? On that diagram, the reason I have it as cool butt, bro, it is about what would go wrong if that area had a lesion, okay? So on the posterior, if you had a lesion, it would be cold, okay? In the anterior portion, if you had a lesion, you would experience a lot of heating, all right? All right, so as we kind of teased before, the posterior pituitary is not a true endocrine gland in the classic sense. It does not synthesize any of its hormones. Remember, that comes from the hypothalamus. ADH and oxytocin are synthesized in the hypothalamus, then transported down the axons, stored in the posterior pituitary, then released into systemic circulation. So this is neuroendocrine signaling, that merging of neurons and endocrine. If this pathway gets damaged, you will actually get diabetes insipidus. Diabetes insipidus basically just means you have a deficiency of ADH, okay? Antidiuretic hormone. Remember? Our little buddy from renal. So then the result, right, if you have a deficiency of ADH, you'll have the inability to reabsorb water, excess urination, or polyuria it's also called, excess thirst, polydipsia, and then finally you'll have dilute urine because of all of the above reasons. So this is completely different from diabetes mellitus, which, remember, involves glucose. All right, so our pancreas. All right, so the pancreas has both exocrine and endocrine functions. The exocrine pancreas has acinar cells, which secrete digestive enzymes like amylase, lipase, proteases into ducts, and then finally into the duodenum of your gut, and then finally digestion. The endocrine pancreas, the guy we're interested in right now, has clusters called islets of Langerhans, which regulate blood glucose. So the key islet cell types are alpha cells, beta cells, delta cells, and F cells. Alpha cells secrete glucagon, which increases blood glucose. Beta cells have insulin, which decrease blood glucose. Delta cells secrete somatostatin, which has inhibitory effects. And then F cells, very low yield. Honestly, like, don't even really remember this, but this is just for completion's sake. All right. F cells have they secrete pancreatic polypeptide. All right. It can come up, but honestly, alpha, beta, delta should do you right. And I just like to think of these guys as our glucose thermostat. All right, so insulin versus glucagon core actions. So insulin is released when glucose is high, okay, or right after you ate. So the core effects here will be an increase in glucose uptake in muscles and adipose tissue via your GLUT4 transporters. You will have an increase in glycogen synthesis because you want to pack away all that sugar. You're going to have an increase in lipid synthesis. You want to pack away all that fat. And you're going to have a decrease in gluconeogenesis, which is basically just new glucose production. Because why would you be wanting to make new glucose when you are literally eating it? You glutton. So insulin is anabolic. It builds and stores. All right? It is a builder, which is why we have Mr. Bob the Builder to represent insulin. Glucagon, on the other hand, is released when glucose is low. I like to remember that because when the gluc is gone, glucagon shows up. So the core effects here are going to be an increase of glycogen breakdown. You want to be breaking down those stores, right? An increase in gluconeogenesis. You now want to be making more sugar because you don't have any. And then you want an increase in lipolysis because you are at an energy deficit. You want your energy wherever you can get it. Give me the sugar. Give me the fat. Glucagon is catabolic, right? We're breaking things down. It mobilizes stored fuels. And that's why we have lovely Dwight Schrute setting fire to the office, because that's what glucagon does. It's like, hey, we got to burn everything down and use everything right now because we are starving. All right, now we're going to get into type 1 versus type 2 diabetes. So type 1 diabetes is autoimmune destruction of beta cells. So this is absolute insulin deficiency, and you're going to be high risk of diabetic ketoacidosis, or DKA. The reason that is because if you don't have insulin, you're going to have unchecked glucagon, which will lead to lipolysis. And if you're breaking up a bunch of fatty acids, they're going to start making ketones. And if you have a bunch of ketones, you're going to end up with metabolic acidosis. All right? Then for type 2 diabetes, this is insulin resistance. Basically, the cells won't respond properly. So you're going to have a relative insulin deficiency, but not complete. And it's often associated with obesity. So insulin exists, but tissues are resistant. Over time, beta cells will burn out, and that's how you get that resistance. So the key difference here, as described by our lovely images here, so your type 1, you're just not going to have insulin at all. Type 2, just like our lovely boy playing his trumpet right in this girl's ear, imagine the trumpet being insulin and that girl being a beta cell. She just doesn't want to hear it anymore. She's like, hey, you didn't listen to me before? I'm plugging my ears now. So there you go. All right, so DKA versus hyperosmolar hyperglycemic state. So DKA, or diabetic ketoacidosis, is usually only seen in type 1 diabetics. Ketones are present. That's why it's ketoacidosis. It is a metabolic acidosis, believe it or not. And you're going to see an elevated anion gap. Okay, so the mechanism here is no insulin, fat breakdown, ketone production, acidosis. On the other hand, you're going to have HHS, or hyperosmolar hyperglycemic state. So this is usually with type 2 diabetics, and it's just severe hyperglycemia. Like, this is going to be an insane blood glucose level, like above 600 milligrams per deciliter. Okay? And these are going to be minimal ketones, all right? No significant acidosis. And so the mechanism here is going to be enough insulin to suppress ketones, not enough to control glucose, all right? Which is why you're not going to get that DKA. Just to have some general limits here too, to be considered diabetic, you have to have a fasting blood glucose level above 126 milligrams per deciliter. So 600 is insane, right? That's why it's hyperglycemia. That is severe hyperglycemia. Okay, so the pituitary has two functional parts. You're going to have the anterior pituitary, which is glandular tissue and synthesizes hormones, similar to your hypothalamus. And you're going to have the posterior pituitary, which is neural tissue. It stores and releases hypothalamic hormones, right? That ADH and oxytocin. Okay, so you want to be thinking of the anterior pituitary as an active factory and the posterior pituitary as just a storage, okay, which is why we have all these boxes here. When you see posterior pituitary, just think storage, all right? Storage for ADH and oxytocin. All right, so now we're going to get into the anterior pituitary hormones. And honestly, I really recommend just drawing out a diagram of the hypothalamus hormones, then the pituitary hormones, then the target glands. That will make your life so much easier. And if you can get a nice fluid way to do that consistently and quickly, that's definitely something you could bang out in the first 2 minutes of your exam time. Just take your piece of paper, write it out real quick, and boom, you have a cheat sheet for about 50% of the exam questions. Pretty nice. So the anterior pituitary hormones to know here. TSH, which is thyroid stimulating hormone. ACTH, which is adrenocorticotropic hormone. You're going to have FSH, which is follicle stimulating hormone. You're going to have LH, which is luteinizing hormone. You're going to have GH, growth hormone, prolactin, all under hypothalamic control. The targets here will be TSH, will target the thyroid. ACTH will target the adrenal cortex. FSH and LH will target gonads. Growth hormone will target the liver, which will produce IGF-1, which is the growth hormone that actually does what growth hormone sounds like it would do, which is induce growth. So IGF-1 is the one that actually does that. And then finally, you'll have prolactin, which will target mammary glands. All right, and now we're going to have our hypothalamic releasing hormones. So these are just hormones that come from the hypothalamus. So the hypothalamus controls anterior pituitary via releasing hormones. So the big ones to know are TRH, thyrotropin releasing hormone, which will then stimulate the release of TSH from the pituitary. CRH, which is corticotropin releasing hormone, which will stimulate ACTH release from the anterior pituitary. GnRH, which is gonadotropin releasing hormone, which will stimulate FSH and LH release from the anterior pituitary. You will have GHRH, which is growth hormone releasing hormone, which will stimulate growth hormone release from the anterior pituitary. And then finally, you will have dopamine, which simply inhibits prolactin release from the anterior pituitary. So, yeah, just important there that prolactin is under tonic inhibition by dopamine. So if you remove dopamine, you have prolactin increasing, all right? And like I said, I really recommend start with a top row of all the hypothalamus hormones, then do a bottom row of all the pituitary hormones, then have little arrows connecting what stimulated what, and then from there do the target glands. And that will help you so much conceptualize a lot of this, okay? All right, and now we're going to get into these guys in a little bit more detail, starting with growth hormone. So growth hormone is produced by somatotrophs in the anterior pituitary. Okay, so whenever one of these hypothalamic hormones gets released, it targets a troph. Okay, that's like the suffix they all share. And somatotroph just happens to be the one for growth hormone. Okay, and once that somatotroph gets stimulated, it releases growth hormone. Okay, that's the idea behind the trophs there. So somato is Latin for body, troph is troph. I don't really know that one, but you know that it's going to have to do something with your body. And growth hormone, spoiler, makes you grow. So it's stimulated by GHRH, which is growth hormone releasing hormone. And it's also stimulated by ghrelin. So when you're hungry, it's inhibited by somatostatin, okay, which is the big inhibitor from the hypothalamus. It pretty much inhibits everything. And GH, or growth hormone, acts indirectly, remember, via that IGF-1 that comes from the liver, okay? So growth hormone is the signal, but IGF-1 is the thing that actually does the growing. And it's actually the thing that you want to be measuring when it comes to growth hormone activity. So if there's any question that's like, oh, you have a patient coming in with so-and-so abnormalities that are consistent with some growth hormone stuff, and they're going to really try to push you towards picking the growth hormone option, do not do that. IGF-1. IGF-1 is the one that actually does the growing. Unless, of course, they're asking about the signal. In that case, it is growth hormone. Sorry, I don't mean to beat a dead horse, but this is like a really free point. And I know you guys can remember this. I believe in you. All right, so now we're just going to get into some growth hormone key effects and excess versus deficiency. So the key physiological effects are going to be bone growth in children, protein synthesis is going to be upregulated, lipolysis, so breaking down fats, will actually increase, and then blood glucose will increase, okay? You're going to have an anti-insulin type of effect. Kind of, you're breaking down a lot of things, right? Remember, insulins are Bob the Builder, Dwight Schrute is our glucagon, right? So you're going to have an anti-insulin-like effect. You're breaking a lot of things down. Growth hormone increases glucose because it decreases insulin sensitivity and increases gluconeogenesis. If you have too much, right, in adults, you're going to get something called acromegaly, and that's going to be enlargement of the hands, feet, jaw, and soft tissue in general. In children, you'll get gigantism if growth plates open. If you have growth hormone deficiency, which is only really seen in children, you're just going to have growth failure, just really, really short kids. So growth hormone excess will mean enlargement, growth hormone deficiency, you're short. So shout out to my short kings and queens out there. Not your fault, for real. All right, now we're moving on to prolactin. So prolactin is produced by lactotrophs. There are those trophs again, lacto, milk stuffs, okay? So, and it's going to be in the anterior pituitary gland. So the primary control here is going to be that dopamine inhibition from the hypothalamus, okay? So it's normally inhibited by dopamine. The function here is that it stimulates milk production. And an important exam concept here is high prolactin will actually suppress gonadotropin-releasing hormone, okay? So if you suppress gonadotropin-releasing hormone, it will decrease that FSH and LH, which are the hormones associated with it, and that will actually lead to infertility. And we'll get into that later, but just bringing it up here. So symptoms of hyperprolactinemia, which it means a ton of prolactin, are going to be galactorrhea, so milk production outside of pregnancy, amenorrhea, so you're going to have basically no period cycle, infertility, erectile dysfunction, and decreased libido. All right, so too much prolactin is basically like, imagine, the way I like to think about it, because initially prolactin was a little bit confusing for me because I was like, oh, milk production, you have a baby, so you had sex to do that. So like, why is it that if you have too much of it, it causes infertility? And it seems to be all these things that are anti-reproduction. I just like to think of it as the tired mom, man. If you look at any like nuclear household, and you look at like the 50s and it's like the mom that's popping all those pills and she's like stressed out because she's basically holding this family together while the husband's out cheating, right? It's horrid. She's stressed out. She wants to die. It's the worst, right? She doesn't want to have sex with her husband. Everything's miserable, right? But she's a mom, right? That's the unfortunate burden. And so that's kind of how I like to remember prolactin. It causes that super, super unfortunate motherhood status. Not that all motherhood is like that. That's not what I'm saying. I'm just saying the easy way to remember that prolactin really does all these negative side effects outside of just, hey, you make milk now. Think of all those hardworking moms out there and all the stress they have to endure. All right, so here is our boy ADH, or if you watch the renal video, you know him as our boy Pissmaster, dude. Love a reoccurring character. So ADH, or antidiuretic hormone, also called vasopressin, or also called Pissmaster here at MooseMed, is produced in the supraoptic nucleus, okay? It is also produced by the paraventricular nucleus. They both work together for this. It is stored and released from the posterior pituitary. Remember, that is that storage, okay? There are only two that are stored there, oxytocin and ADH, our boy. So the primary target here is going to be the collecting duct of the kidney. And the mechanism is ADH is going to bind to a V2 receptor on principal cells of the collecting duct. That will then activate cyclic adenosine monophosphate, also known as CAMP or CAMP. It will insert aquaporin 2 water channels into the apical membrane, and then water will then be reabsorbed into the bloodstream. In short, if ADH is high, your piss will be very, very yellow because you are sucking out all the water. That is the sole reason behind ADH. It's, hey, we noticed your blood volume's low. We need more blood volume. Great, let's take it out before you pee it out. And that's why it produces very yellow piss, and that is why our boy ADH is also known as piss master. All right, so ADH regulation. So ADH release is stimulated by, one, plasma osmolality. So you're going to have an increase in osmolality, which again is that concentration of solutes in the blood. So if you have an increase of it, you have way too many solutes for how little water you have. And it's detected by osmoreceptors in the hypothalamus. So if blood is too concentrated, body wants water, so ADH will increase. The second stimulator will be a decrease in blood volume, and this is detected by baroreceptors, okay? And those baroreceptors are located in the carotid sinus and the aortic arch. It's low yield for an endocrine exam, but just throwing it out there for completion's sake. So that low volume will cause ADH to increase to conserve that fluid. So excess ADH, though, will cause hyponatremia, okay? Too much water retention means that your sodium is diluted, which means low sodium concentration. And this can occur in syndrome of inappropriate ADH secretion, also known as SIADH. And so a deficiency of ADH would be diabetes insipidus. And there are two types of it. You're going to have central diabetes insipidus, which means not enough ADH is being released. And then you'll have nephrogenic diabetes insipidus, which simply means the kidneys aren't responding to ADH that is in fact there, okay? The result will be large amounts of dilute urine and a really intense thirst, okay? So the key logic here is too much ADH, you'll have dilution, too little ADH, dehydration, or in the fantastic way MooseMed puts it, all right? Because here at MooseMed, we go the full mile using that fantastic Megamind image. If you have no ADH, okay, your pee is going to look very blue. Look how sad Megamind is. No ADH? Oh my gosh. That means that you are not sucking any water out of your pee. It is going to be very dilute. Hey, if you have a ton of ADH, what do we also know ADH as here? Pissmaster. That's right. Can we get a Pissmaster count going? This is just going to be an experiment of how many times MooseMed can say Pissmaster in one video. But promise you, after this, you will never forget ADH. But remember, ADH will cause all that water to leave your collecting tubule via those aquaporin 2 receptors and really concentrate that urine. All right, and now for something completely different. I know you guys are going to really miss all that toilet talk, but I know, we have to move on to oxytocin. So oxytocin, like ADH, is produced in the hypothalamus, and it is released from the posterior pituitary, because remember, that's just our storage space for those two guys. So the function of oxytocin is, one, uterine contraction. So it's going to act on uterine smooth muscle via GQ protein pathway, all right? And this will increase intracellular calcium, and that will eventually increase contraction. The second stimulus will be milk ejection. This stimulates contraction of myoepithelial cells around the mammary ducts, and this is an important distinction here, right? So prolactin is milk production, oxytocin is milk ejection, okay? And the reason we have our boy Goku here is to represent the only relevant case for this exam of positive feedback. It doesn't happen all too often in biology, but oxytocin is an example of it. We've been talking about negative feedback loops. Oxytocin is a very rare example of positive feedback. So actually, every round of oxytocin will cause stronger and stronger and stronger contractions until eventually you give birth. It is also known as the cuddle hormone because after you give birth, there's an intense release of a bunch of all this oxytocin that you've built up, and it makes you basically immediately fall in love with your baby. Isn't it kind of funny how biology just kind of gaslights you into loving something that like destroys you? It's pretty goated. And just to add a little bit more detail there, that positive feedback in labor is caused by cervical stretching. Okay, so that cervical stretch will cause oxytocin release, then that will cause stronger contractions. Those contractions will cause more stretch, and then more oxytocin, and then some, and then, and it goes on to infinity. Or at least until, you poop out your little baby. All right, so the thyroid axis. So the classic hypothalamic pituitary thyroid axis goes like this. TRH, then TSH, then T4 and T3. And T3 and T4 inhibit both TRH and TSH with negative inhibition. Okay? And again, please just draw out that whole little hypothalamus, pituitary, target organ, and this will all come to you. So do not worry. So T3 and T4 specifically. So T4, also known as thyroxine, is the major hormone secreted. It is also a prohormone, meaning it is not active, okay? T3 is also known as triiodothyronine, and it is its active form, okay? It has much stronger receptor affinity. And then you have RT3, which is just reverse T3, and that is inactive. So most T3 is formed peripherally by conversion of T4 via deiodinase enzymes in the liver and other tissues. And the thyroid mostly exports T4, and the body activates it locally. And it's for the same reason the pancreas does the same thing. You don't want those super active enzymes active in the organ that's making them. Otherwise, you'll have unpredictable consequences, right? And so like for the pancreas, that would be like pancreatitis, right? If you activate those enzymes within that pancreas and they start eating away at it. Similar here, you don't want to be activating T3 because it's so freaking active. It could cause problems. So to represent that, we have our lovely two apes at the bottom here. We have the distinguished apes telling you to try the bananas, darling. They're dashing. Okay, that's your T4, all right? He's calm. He's collected. He makes up most of society, all right? He's the major hormone secreted, all right? But then on the right here, you have this uncivilized ape. Look how angry he is. So angry, so active, huh? Okay, that's T3, all right? Very, very active, very, very aggressive. And RT3, and the reason we bring up RT3 is because that deiodination, the only difference between T4 and T3 is an iodine group. So no wonder that something called a deiodinase enzyme is the thing that changes it, okay? Because you're removing that iodine. T4, 4 iodines, T3, 3 iodines. Oh my gosh, pretty cool, right? So the reason we have RT3 is if an enzyme known as 5-deiodinase does the cleavage, it cleaves the wrong iodine and you get a reverse. It's basically like a mirror image of T3. And if you took OChem, if you're in med school, you definitely did. You know about chirality. Ooh, jump scare, chirality, right? If something's the mirror image of something, that doesn't always exactly mean it's the same thing, right? Things get tricky with chirality. So, the key here is that the enzyme that you do want to be using is 5'-deiodinase, okay? That will actually give you T3. So just 5-deiodinase will give you RT3, which is inactive. 5'-deiodinase will get you T3. All right, so now we're going to get into the mechanism of thyroid hormone. So again, thyroid hormone is lipid soluble. It binds intracellularly because of that, and it will alter gene transcription. So the mechanism here is you're going to have T3 enter the cell. It's going to bind a thyroid receptor in the nucleus. That receptor will then bind DNA at thyroid response elements, and that will then change transcription of metabolic genes. So the major effect here is going to be a net increase in basal metabolic rate. And basal metabolic rate is the base energy required to keep you alive, okay? Basically, the base energy used at rest, all right? It increases oxygen consumption, heat production, and mitochondrial activity. So it amplifies metabolism everywhere. All right, now we're going to focus on that iodine we were talking about earlier. So iodine is the rate-limiting step here. So iodine is essential for thyroid hormone synthesis. So the steps here are iodide uptake via the sodium iodide symporter. And notice how I said iodide. Okay, iodide is just charged iodine, but it's important that you know that it comes in as iodide. Okay, so it's going to come through that sodium iodide symporter through secondary active transport, and then iodide will be oxidized by TPO, or thyroid peroxidase. And TPO is a pretty awesome enzyme because it does a lot of things for this. All right. Then the third step here will be iodination of tyrosine residues on the thyroglobulin. And thyroglobulin is a protein that is synthesized. It's basically the base of T3 and T4 and what they're built off of. And then you will have the tyrosine residues, which is an amino acid, right? And that's what gets iodinated. And then the final step will be coupling to form T3 and T4, okay? And basically, after we've gone through our iodination, we're going to have DIT and MIT. And DIT stands for diiodinated thyroglobulin, and then MIT stands for monoiodinated thyroglobulin. And you know, if you take two diiodinated things, so two iodines, and you put them together, so 2 and 2, you're going to get 4 iodines. Guess what that's called? T4. Oh my gosh. If you take a DIT, so that diiodinated thyroglobulin, and then MIT, monoiodinated thyroglobulin, guess how many iodines that is? 3. Oh my gosh, T3. So there you go. With an iodine deficiency, you'll get something called a goiter. So low iodine will lead to low T3 and T4 synthesis, which means that you're going to have a really high TSH signal, right? So that's that hypothalamic hormone, right, to stimulate T3 and T4 production. And if there's no T3 and T4, it's going to be like, what the hell, guys? We need more. We need more. And it's going to keep stimulating it and keep going, come on. And so TSH is going to stimulate that thyroid growth, which will cause your gland to enlarge. And so a goiter is basically just an enlargement from chronic stimulation. All right, so hypothyroidism. So when we talk about hypo and hyper, those prefixes are in relation to the thyroid hormones themselves, which are T3 and T4, collectively known as thyroid hormone, okay? So hypothyroidism, that's going to have low T3 and T4. And you're going to see high TSH for the reasons stated before, right? If you're not going to have T3 and T4, that signal is going to increase a ton because it really wants to compensate. So the symptoms will reflect a decrease in metabolism. You're going to see fatigue, cold intolerance, weight gain, bradycardia, so slow heart rate, constipation, dry skin, depression. Everything basically just slows down. Slow, okay? A severe untreated case could lead to something called a myxedema coma, which is life-threatening. All right, and now we have hyperthyroidism. And the lab pattern here is the exact opposite. You're going to see an increase in T3 and T4 levels and a decrease in TSH, right, because of that negative inhibition. If you have a ton of T3 and T4, they're going to be like, hey, hypothalamus, dude, stop telling us to be made. We're super high right now. It's great. So the most common cause here will be Graves' disease. So autoantibodies will stimulate the TSH production. That thyroid will then overproduce hormone independent of TSH. So basically it's actually a rare case. Usually when you have autoantibodies, they usually inhibit something. This is a rare case where they actually activate something, okay? And so these autoantibodies are going to stimulate overproduction of T3 and T4. The way I like to remember hyperthyroidism, if you've ever seen the movie with Will Smith, I Am Legend, those zombies in that movie are like almost like a perfect example of like what a sci-fi extreme version of hyperthyroidism would look like, because they are, one, very lean, they are super irritable, okay, and they have really bulging eyes at times. Okay. And again, that's going to be because you're basically metabolizing incredibly fast. Okay. So you're going to be kind of hot to the touch. Okay. You're going to be very, very lean. Again, you might see a goiter. You could also get a goiter in hypothyroidism. That's why I'm trying not to focus on it too much, because it does appear in both. But the big key things here are going to be Graves' disease, so the bulging of the eyes, the irritability, and also super, super sensitive to hot temperatures, because you're already running super, super hot. All right, so the starvation effect. So during starvation, you're going to see a decrease in peripheral conversion of T4 to T3, and you will see an increase in reverse T3, the inactive form. So TSH is often normal, okay? And so the purpose here is, so lower active thyroid hormone will mean a decrease in basal metabolic rate, which means you're trying to conserve energy, right? If you're not giving your body energy, it's going to be like, well, okay, I'm going to take a really, really long time breaking up the stuff I have, okay? This is adaptive. It's not true hypothyroidism. This is basically your body trying to save you from starving. And this is also why just immediately starving yourself to lose weight just doesn't work, and you'll most likely end up putting on that weight and then some afterwards, because you're going to increase your sensitivity to hunger signaling. And then also you're going to have that decreased metabolic rate in general, right? So when you eventually eat something, and assuming it will be a normal portion size, because you've been starving yourself, your body's going to be like, oh my gosh, look at all this extra food we have now. And it's going to end up storing a ton of that stuff, because you're basically waking it up out of a starvation state. All right. So the adrenal gland has two distinct parts. You're going to have the cortex, which is the outer layer, and that produces steroid hormones. And it's going to have three zones. You're going to have the zona glomerulosa, which produces aldosterone. You're going to have the zona fasciculata, which produces cortisol. And then you have zona reticularis, which produces androgens. And these are all derived from cholesterol. Then you're going to have the medulla, okay? And this is the inner core. And this produces catecholamines. And the way I like to remember this is because the medulla yearns for the mines, the catecholamines, all right? And the medulla is towards the middle, right? It's down deep there. It looks like a little cave. So there are mines and caves. There you go. So these catecholamines are epinephrine and norepinephrine, and these are modified tyrosine derivatives. They act via adrenergic receptors, meaning they will produce a sympathetic-like response or fight or flight response. And so if you needed a general way to group these two things, the cortex is slow genomic steroid hormones, whereas the medulla is fast catecholamine surge. Okay? Two tissues, two signaling styles, same gland. All right, and now we're going to just zoom in on the adrenal cortex. So the adrenal cortex has three layers. Like we said, we have that glomerulosa, the fasciculata, and the reticularis, and all producing aldosterone, cortisol, androgens respectively, okay? And the reason they all produce different things is because of the enzymes that are in those specific layers, okay? All are steroid hormones derived from cholesterol, like we said before, and you can just remember it as the GFR rule, or it's a good fucking rule. There you go. And so the top layer, which is closest to the blood supply, controls volume, blood volume, right? That makes sense, aldosterone. The middle layer is stress and metabolism. And then the deep layer, the cortex, is sex hormone precursors, those androgens, okay? All right, now we're zooming in one layer deeper on just the individual steroid hormones. So aldosterone, it's produced by the zona glomerulosa of the adrenal cortex, okay? And it's regulated primarily by RAS, the renin-angiotensin-aldosterone system. Renal jump scares all over this video today. So the mechanism here is low blood pressure or low renal perfusion will lead to kidney releasing renin. The renin converts angiotensin from the liver to angiotensin 1. ACE from the lungs converts angiotensin 1 to angiotensin 2. Then angiotensin 2 will finally stimulate aldosterone release from the kidneys. So aldosterone acts in the distal nephron, okay, collecting duct principal cells, to be specific. And the effects here are going to be an increase in sodium reabsorption, an increase in water retention, because water follows sodium, and an increase in potassium excretion. And the net effect here will be an increase in blood volume and then an increase in blood pressure. It is a volume hormone, not a glucose hormone. All right? Cortisol is produced by the zona fasciculata and is regulated by ACTH, or adrenocorticotropic hormone. Okay? Cortisol is what's called a glucocorticoid. All right? So the major effects here will be an increase in blood glucose. All right? So the whole point here is to increase that blood glucose. It's going to stimulate gluconeogenesis in the liver, building up that glucose. It's going to obviously oppose insulin, stimulate lipolysis, which is, again, breaking down that fat for energy, protein breakdown in the muscle, and it's going to have an anti-inflammatory effect. So it's going to suppress immune signaling, and it's going to decrease cytokine production. So cortisol prepares the body for stress, and it mobilizes energy and suppresses non-essential systems. An easy way to remember that anti-inflammatory aspect of it is just, when you get stressed out, your immune system just plummets. I know when I get stressed out about exams and whatnot, I get sores inside my mouth. I just become like a wreck. I start getting sick super easily. It's horrible. My body just starts attacking itself. So, this one's pretty easy for me to remember because, school is stressful. But, if you needed a little vignette, there you go. All right, now we're going to get into the clinical correlations of cortisol, and there are two. So Cushing's is an excess of cortisol, and this can be exogenous from steroid therapy. It could be from an ACTH producing tumor. It could also be from an adrenal tumor. So the classic findings here are going to be what's called moon face, central obesity, muscle wasting, thin skin, purple striae, which are purple purple striations across the skin, and then hypertension and hyperglycemia. And then the mechanism logic here is going to be the fat is redistributed centrally, muscle breaks down, and then skin collagen decreased, which will cause that thin skin and striae, and then glucose is elevated due to gluconeogenesis. And so basically high cortisol all will lead to an exaggerated stress physiology. And so now we're going to move on to the opposite of Cushing's, which is Addison disease. And this is going to be not enough cortisol. And the problem is at the adrenal gland level. This is also known as primary adrenal insufficiency. So be careful of that in vignettes. Sometimes they won't name drop Addison for the specific purpose of they don't want you to recognize the name, and we'll just say primary adrenal insufficiency to see if you're able to make the connection, or vice versa, because there could be someone that studied it as primary adrenal insufficiency and not Addison, et cetera, et cetera. Anyway, the findings you'll see are a decrease in cortisol, right, because that is the core problem here, a decrease in aldosterone, and then an increase in ACTH. So why is ACTH increasing? Well, that's because of negative feedback. So a loss of cortisol, which is a downstream product of ACTH, will cause it to increase a ton. It's like, hey, where did that product go? I need more of this now, right? So ACTH is derived from what's called POMC, or pro-opiomelanocortin, which also produces MSH, or melanocyte stimulating hormone. And that causes pigmentation. So any sort of problem with that will result in hyperpigmentation. So low aldosterone will lead to sodium loss, will lead to hypotension and hyperkalemia, whereas Addison's is low hormones, high ACTH, and then also dark skin as a byproduct of that with that hyperpigmentation. All right, so the adrenal medulla is, again, that inner portion of the gland, and it produces epinephrine and norepinephrine. And again, these are catecholamines derived from tyrosine, and it's regulated by preganglionic sympathetic fibers. Also, acetylcholine stimulation, okay? The function here is going to be a fight or flight response, and the effects are going to be an increase in heart rate, increase in blood pressure, increase in glucose, bronchodilation, And unlike the cortex, which has slow steroid signaling, the medulla is rapid and neural. All right, so PTH. So PTH stands for parathyroid hormone, and it's secreted by the chief cells of parathyroid glands. The primary stimulus here is a decrease in serum calcium. Parathyroid glands sense calcium via calcium-sensing receptors, also known as CASR. And so low calcium will lead to PTH being released. So PTH's actions. So on bone, it's going to stimulate osteoclast activity indirectly, and that will cause a release of calcium. Okay, so clasts are the guys that break up bone. So if you're breaking up bone, you're going to release calcium. Kidneys are going to react to PTH by increasing calcium reabsorption. Okay, they're going to increase phosphate excretion, and they're going to increase activation of vitamin D via an enzyme called 1-alpha hydroxylase. The goal here is just to increase serum calcium. All right, so the vitamin D role here. So the active form of it is calcitrol, also known as 1,25-dihydroxyvitamin D, if you wanted the full legal there. And that 125 at the beginning of that name is very important because without that 1 there, it is not active. So if you see just 25-dihydroxyvitamin D, that is inactive. The 125-dihydroxyvitamin D, that's what makes it active. So vitamin D3, also known as cholecalciferol, is formed in the skin. And then vitamin D2, ergocalciferol, is from your diet. So the activation of vitamin D, because it's not active on its own, it doesn't just work. It has to go through a bit of a process. So the first stop is the liver, where it's going to get a hydroxy group on the 25th carbon. Then it's going to go to the kidneys, who are stimulated by PTH to hydroxylate the first carbon using that enzyme 1-alpha hydroxylase. Okay? So active vitamin D will increase GI calcium absorption. It will increase phosphate absorption. And then it works synergistically with PTH to raise serum calcium. So vitamin D increases supply, PTH mobilizes and conserves. So that's the important distinction between the two. PTH, you'll see an increase in calcium, but you'll see a decrease in phosphate because it stimulates the excretion of it. Whereas vitamin D actually stimulates an increase in both calcium and phosphate. Okay, so now we're going to get into hyperparathyroidism. Okay, so with hyperparathyroidism, you're going to see an excess of PTH. And again, PTH, parathyroid hormone. So the lab pattern you'll see here is that increase in calcium and a decrease in phosphate for similar reasons to what we stated in the previous slide there. So the mechanism here is going to be bone resorption plus renal phosphate wasting. Okay, so the symptoms of hypercalcemia are kidney stones, shortened QT intervals on your ECG, weakness, dehydration, hypertension. So high PTH basically will lead to bone breakdown because it wants to increase that calcium, that systemic calcium, and will eventually lead to hypercalcemia down the line. It is important to note that there are 3 types of hyperparathyroidism. Okay, I am just going to throw up the chart here, but I recommend just drawing this out yourself and reasoning through it with the tools that I have provided, and then maybe watch a couple supplementary summary videos on the afflictions. So now we're going to get into steroid therapy logic. So exogenous steroids like prednisone mimic cortisol. Okay, so chronic use of these steroids will suppress ACTH via negative feedback, right? Because cortisol also has that negative feedback. So if you bring in something that acts like cortisol, it will also do that negative feedback. And then the adrenal cortex will actually atrophy. So if abruptly stopped, the body cannot produce endogenous cortisol quickly. So the risk here is actually acute adrenal insufficiency. All right. So therefore, steroids must be tapered gradually. So the taper allows ACTH to recover and adrenal regrowth. It's kind of similar to melatonin, where it's like if you take melatonin every single night, you're going to reduce your body's intrinsic ability to produce melatonin, okay? Because your body's like, hey, I'm getting supplemented this, so why do I even need to keep making it? So steroids are similar in that sense. So beta blockers and hyperthyroidism. And the reason we have a slide for this is because this is going to be this is either going to be a straightforward question on an exam or it will be a bait and switch option. Okay, so beta blockers and hyperthyroidism. So the key concept here is beta blockers do not reduce thyroid hormone levels. They reduce sympathetic symptoms that are caused by that hyperthyroidism. Okay, so why those symptoms occur. So T3 and T4, they cause sympathetic-like symptoms. So they're going to increase beta-adrenergic receptor expression. They're going to increase sensitivity to catecholamines. And so the result here will be tachycardia or increased heart rate, tremors, anxiety, palpitations. And so something like propranolol, a non-selective beta blocker, will block beta-1, which is heart rate, and blocks beta-2, which is your lungs. And at high doses, it will decrease T4 and T3 conversion. So methimazole, which we'll get into all these drugs later. I have a whole slide for it. So if anything, I'm just kind of giving you a little bit of trauma on the front end. So when we eventually get to the bulk of it, it won't be as scary. But methimazole fixes hormone production. Okay, that's what you would actually want to use for hyperthyroidism. Beta blockers will simply alleviate those symptoms. Okay, and that's why we have good old Will Ferrell giving you the thumbs up there, because beta blockers, they'll make you feel a little better. They won't fix the problem though. Like they're fine. They're fine, but they won't fix it. All right. So remember how I said that I was going to front end the pharmacy trauma? Well, here it is. One slide later. Welcome to the high yield endocrine drugs boogaloo. All right. I'm just going to run through these. Honestly, throw these on an Anki deck, flashcard, just drill these, write them on a whiteboard. Watching this video will only help you if you have already done a couple passes of this. So, the thyroid gland. The drugs you want to know are levothyroxine, which is a fancy word for T4 replacement. So this is going to be a treatment for hypothyroidism. And the reason we want to do T4 is because our body can then innately convert it into T3. There is another drug that I did not list on here, but it's called leotriaothene. It's another Leo, but it's not levothyroxine. It doesn't have a V in it. And it's basically T3 replacement. And you do not want to use that as a first line defense. That is like severe hypothyroidism, you give it to them. And that's, again, for those reasons stated before, how T3 is a much more active hormone, okay? So we want to try to keep it in that pro-hormone stage so that our body can take care of it from there, which is why we prefer levothyroxine. Then you're going to have methimazole, which we just talked about, and that's going to inhibit thyroid hormone synthesis, and that's going to be your first line of defense against hyperthyroidism. Then you're going to have PTU, also known as propylthiouracil, and that's going to inhibit thyroid synthesis and peripheral conversion of T4 to T3. And the way I like to remember this guy is PTU sounds like a gun, like pew pew pew. And if you're using a gun, you're probably gonna you're gonna kill everything to do with thyroid synthesis. So you're not gonna be making it. You're not gonna be converting it. You're just gonna shoot. You're gonna shut that whole operation down. And again, beta blockers, as stated before, will control hyperthyroid symptoms, but they won't necessarily treat. So adrenal drugs. So the first one here will be hydrocortisone or prednisone, and these are glucocorticoid replacement. And you want to be using these in Addison's disease, right? So that primary adrenal insufficiency or inflammatory disorders. So hydrocortisone resembles endogenous cortisol, okay? And prednisone is converted to prednisolone in the liver. The next thing you're going to have is fludrocortisone, all right? I'm doing my best with the pronunciations here, which is a mineral corticoid replacement. And this is used when aldosterone is deficient, okay? And this is for primary adrenal insufficiency as well. And this will restore sodium retention, volume status. The next one we have here is dexamethasone, and this is a potent glucocorticoid, and this is used in dexamethasone suppression test, which is a Cushing workup. And the details here is, remember, Cushing's, you're going to have that super excess cortisol production, okay? So if you have something that normally is going to suppress that cortisol production, right? When you administer it, ideally, you will see a decrease in cortisol. So a way to find out if someone has Cushing's or not, you give them dexamethasone in hopes to suppress cortisol, right? But the key here is that you give a low dose, because in a healthy person, any dose of this should suppress cortisol in some way, shape, or form. Specifically with Cushing's, if you give them a low dose of dexamethasone, you will not see a decrease in cortisol. It will stay elevated. The key here is, though, if you give too much dexamethasone, it will actually work and it will decrease cortisol levels, okay? So that's why it's specifically low dose dexamethasone suppression test, okay? All right, so then pancreas and diabetes drugs. So insulin, that's going to be required for type 1 diabetes, and that's, again, an absolute deficiency. You're going to have no insulin. So obviously, giving insulin will help. That will present with severe hyperglycemia and that diabetic ketoacidosis. And again, you're just replacing a missing hormone. The next one will be metformin, and this is a first-line defense in type 2 diabetes. So the mechanism here is going to be a decrease in hepatic gluconeogenesis, okay? And it's going to be an increase in insulin sensitivity. And this is because, again, right, you're not secreting insulin in type 2 diabetes as much because of that resistance to those signals from those pancreatic islets, right, from those B cells. And so instead, what metformin hopes to do is to increase your sensitivity to it. So what little insulin you do end up receiving ends up having a pretty solid effect. And hopefully it's able to compensate. All right, so finally, at the end of this drug boogaloo, we have ADH and posterior pituitary drugs. So the first one will be desmopressin, or DDAVP. And this is a synthetic ADH analog. So it's selective for V2 receptors in the kidney, and it's used in central diabetes insipidus, which again is that low ADH production. The mechanism here will be activating V2 receptors, which will then insert aquaporin 2 channels, and then that will increase water reabsorption. It does not significantly cause vasoconstriction. And so with central diabetes insipidus, you're going to have no ADH production at all. And so that's when you would want to treat with desmopressin. Whereas with nephrogenic diabetes insipidus, when the kidneys are the problem in that they don't respond to the ADH that's being secreted, this desmopressin, unfortunately, will not work. All right, we made it to the final slide. So every endocrine question reduces to 4 steps. What hormone is abnormal? So look at the labs. Where is the defect? The hypothalamus, the pituitary, the target gland. What feedback pattern should exist? AKA, like, high target hormone means low upstream hormone. So that would be normal negative feedback. If that pattern breaks, that means the pathology is occurring. What symptoms match the physiology? So high metabolism, heat intolerance, low cortisol, hypotension, high calcium, stones and weakness, right? So endocrinology is pattern recognition built on feedback logic. If you can track feedback loops and match physiology to symptoms, you are set for this exam, all right? So again, do draw out those charts. They will really, really help you. Muscle memory is a thing, and if you get it down quick, those first 5 minutes on your exam, just take out your cheat sheet, write that all out, you're golden, all right? All right, and now we are finally done. Thank you, as always, for stopping by MooseMed, where we take medicine by the horns, or for all intensive purposes, moose have antlers, so technically we're taking it by the antlers, but who cares? Thank you so much. This has been fun, I think. I hope you learned a lot, and good luck on whatever exams you're taking. See you next time.